So, welcome everybody to the 13th annual conference of the Midwest Injury Prevention Alliance. The title of this year's summit is Moving Forward, which is our Wisconsin logo forward, um, Innovations in Injury Prevention Practice. I'm Sara Kohlbeck. I am the president of MIPA, and I've been part of MIPA for about 3 years. And for those of us who might be joining a MIPA event for the first time, the Midwest Injury Prevention Alliance, or MIPA, is an organization of injury professionals from the 6 states in the federal HHS Region 5, which is Illinois, Indiana, Minnesota, Michigan, Ohio, and Wisconsin. And we work together collaboratively to reduce unintentional and intentional injury-related death and disability. MIPA is similar to the Great Lakes and Mid-Atlantic Regional Network and other networks, which is formerly known as the Regional Network Collaborating Organizations. But its establishment actually predated the creation of these networks by the CDC. And the mission of MIPA is to facilitate development of a coordinated approach for unintentional and intentional injury prevention and control in our region. MIPA promotes the development and sharing of injury prevention planning, evaluation, education, and policy strategies, training, research, and other initiatives among members of the MIPA network. MIPA does this with the goal of reducing unintentional and intentional injuries by fostering collaboration and communication among the MIPA network members. And this year, we are welcoming close to 300 attendees for our annual conference, so welcome. And we are really excited to have a fantastic program for you today. We have a wonderful opening keynoter, which we will introduce in just a moment, but we also have an exceptional panel discussion. And as I mentioned, 2 outstanding keynote sessions on highly relevant injury and violence prevention topics. We do also have 2 breakout sessions and a lunch break where you can feel free to mingle or attend to other matters. And I do just want to mention that we do have one change to our schedule for today. Our falls prevention session is now going to be led by Alfred Johnson, who is our current MIPA secretary and is with the Wisconsin Department of Health Services. So just a slight change on the speaker for that session today, if you're planning on attending that falls prevention session this afternoon. I do just want to, before we start, have a couple of different thank yous. Mention a couple of folks. First off, the conference planning committee that has been working together for months to put together this great program for you today. So thank you so much to everyone who has done that. I also want to thank the MIPA committee chairs for suggesting conference session topics and speakers, and in some cases, being the main speaker in their session. So thank you. I also want to thank all of our speakers, including our keynote speakers, our panel moderators, and our panelists. And finally, our hosts, the Comprehensive Injury Center at the Medical College of Wisconsin here in Milwaukee, Nationwide Children's Hospital in Columbus, and also the Minnesota Department of Health Injury Prevention Unit. And again, we want to thank our hosts for their vital support for this conference. And so if we could give folks just a virtual round of applause, that would be great. Just a couple of announcements before we get started. We do welcome you to take advantage of the various networking capabilities of our conferencing platform, visiting with the people in the chat on the side of your screen, participating in the polls, and also using the networking options during the breaks and during lunch. You can find these tools in the networking tab alongside of the screen, and you can also chat or use the match tool to be matched with attendees for networking. So definitely take advantage of the different capabilities that we have through this platform. As I mentioned, we will have a lunch break, and during lunch, we invite you to grab your own lunch and network, or simply take a break and join us back in time for the afternoon sessions. We are trying something new this year as well. We have some exciting MIPA member highlight videos that will be available for you to view during your lunch break as well. So we definitely encourage you to check those out. If you do have questions for the presenters, please use the chat feature. We do have moderators for each session, and those moderators and the speakers will do their best to allow for time at the end of each session to take questions. So again, use that chat feature if you do have any questions. And we also want to let you know that video recordings of each session and any of the materials that are shared by our presenters will be available on the MIPA website following the conference. If at any time during today's conference you are experiencing any technical difficulties, please use or please contact our conference planner, Heather Callier, either in the chat or at mipasummit@gmail.com, and we'll pop that email address. But again, Heather Callier is the person that you can chat if you're experiencing any technical difficulties. And finally, if you are from one of the 6 states in Federal Region 5 and are not already a member of MIPA, please sign up to become a member. That will allow you to receive and share news about injury and violence activities in our region. We also have a number of committees that you can join, including child injury prevention, communications and membership, data, National Violent Death Reporting System, older adult falls or drug overdose. Joining MIPA, you can receive our newsletter, invitations to our webinars, our annual meeting, and much more. And if you're interested in joining, please go to our website at midwestinjurypreventionalliance.org. And again, we will put that in the chat for you so you have that. And it's now my pleasure to introduce Nichole Burnside, who's the Managing Director of the University of Michigan Injury Prevention Center and our incoming 2025 MIPA president, who will provide opening remarks. So Nichole, take it away.
Thank you, Sara. Thank you all for being with us today. Wisconsin is honored to host the annual MIPA Summit this year. Today, we are joined by professionals representing a variety of fields, and our virtual format allows our reach to go beyond previous years. We welcome back returning participants and a special warm welcome to our first-time participants. As Sara mentioned, the summit theme focuses on innovative discovery and practice in the injury and violence prevention field. The power of innovation is essential as we work together for a common purpose. With newer technology and research, we are in a unique position to further our efforts of discovery by applying this to our individual state strategies and activities. We are fortunate through the efforts of MIPA to have a strong partnership among the states in our region in which we can gain knowledge, insight, and lessons learned. Today's summit serves as an opportunity to increase that knowledge and build our partnerships. Each of the presentations today will showcase some form of research to practice, and the virtual platform is a great way to strengthen your connections within the region. I want to personally thank the Summit Planning Committee for organizing an outstanding program. Over the next few hours, you will have the opportunity to meet experts in the field and network with colleagues across the region. The summit will include discussion panel, discussions, conducting analysis, bridging gaps, and being effective and engaging, reducing risk, just to name a few. Let us expand our knowledge of different topics and approaches, in addition to identify strategies we can implement when we return to work and continue to apply what we learned today after the summit. MIPA is a valuable organization which continues to grow each year, and we enjoy having more stakeholders engaged in our efforts. If you are not a member of MIPA, I encourage you to join us. It's no cost, and become involved in one of the MIPA committees. It is now my pleasure to introduce our keynote speaker, Dr. Mullins. Dr. Mullins is the Health Equity Officer in Division of Injury Prevention and at the Centers for Disease Control and Prevention. In this role, Dr. Mullins works to prevent injury by advancing and incorporating health equity through data, science, and action. Dr. Mullins has worked to prevent violence against children and youth and identify evidence-based HIV, behavioral, and medication adherence interventions. She has worked to increase diversity, equity, inclusion, and belonging and accessibility in the workplace and reduce health disparities among disproportionately affected populations. Dr. Mullins is a graduate of Spelman College and the University of North Texas Health Science Center School of Public Health, where her research focused on the social determinants of health. Thank you for joining, Dr. Mullins, and welcome, Dr. Mullins.
Realized I was on mute. Good morning, everyone. Thank you, Nichole, and thank you, Sara. I'm going to go ahead and share my screen. And are you all able to see my slide?
Yes, we can.
Okay, great. Good morning, everyone. It is a pleasure to be invited to address the 2024 Midwest Injury Prevention Alliance virtual conference. Today, I will discuss unpacking social and structural determinants of health for injury prevention. The findings and conclusions in this presentation are mine and do not necessarily represent the views of the Centers for Disease Control and Prevention, CDC, the Agency for Toxic Substances and Disease Registry, ATSDR. For today's presentation, I will go over unintentional and intentional injury prevention at CDC, social and structural determinants of health with an interactive demonstration, provide a few scenarios for our discussion, and finally end with some helpful resources. So before we get started, I have a couple of questions. Can we have the poll questions added to the chat, please? So where are you from in Region 5?
Like we still got some responses coming in.
Okay, great.
And slowing down a little bit here.
Okay, we have a nice, looks like 25% from Minnesota, 25% Ohio, 20% Wisconsin. Okay, I'm a little biased to Illinois. I was born in Chicago, so the 9%, and then 10% from Indiana, and 11% from Michigan. Okay, great. Can we move on to poll question number 2, please? Okay, do you work in unintentional or intentional injury prevention? Okay, it looks like 70%, the majority work at unintentional injury prevention. Okay, thank you, Sara. So the title of my presentation is Beyond the Surface, Unpacking Social and Structural Determinants of Health for Injury Prevention. During this presentation, I want to do just that, go beyond the surface and explore the underlying factors or root causes that impact unintentional and intentional injuries, and not merely look at the surface. As you can see from this picture, there is so much beyond the surface. If we just focus on the surface, we would miss everything that's underneath. So now we'll talk about the work that I'm involved with and talk about unintentional and intentional injury prevention at CDC. This slide shows the top 10 leading causes of death in the US for ages 1 to 44 from 1981 to 2022. Injuries and violence affect everyone, regardless of age, race, or economic status. In the first half of life, more Americans die from injuries and violence, such as motor vehicle crashes, suicide, or homicides, than any other cause, including cancer, HIV, or the flu. This makes injury the leading cause of death among persons aged 1 through 44. Suicide is now the second leading cause of death for people ages 1 through 44, and numbers of suicides continue to rise. Homicide remains in the top 5 leading causes of death for the 1 through 44 age group. In addition, drowning is the #1 cause of death for children ages 1 through 4. Motor vehicle crashes are a leading cause of death in the United States among people ages 1 to 75, and a leading cause of death for children, youth, and young adults ages 5 to 24. Falls are the leading cause of fatal and non-fatal injuries among adults aged 65 years and older, and people ages 75 years and older had the highest numbers and rates of TBI-related deaths. This age group accounts for about 28% of all TBI-related deaths. As noted in the previous slide, unintentional injuries are the leading cause of death for Americans aged 1 to 44 years old. The leading causes of death for unintentional injury include unintentional poisoning, for example, drug overdoses, unintentional motor vehicle traffic, unintentional drowning, and unintentional falls. Now I'll talk specifically about the National Center for Injury Prevention and Control, or the Injury Center. The Injury Center works to protect Americans from injury and violence. Since 1993, the Injury Center has established itself as a leader in protecting Americans from injury and violence. Our mission is to prevent injury, overdose, suicide, and violence across the lifespan through science and action. We work proactively with our partners to track trends, conduct research, raise awareness, and implement programs to prevent injury and improve public health. For more than 30 years, the Injury Center has continually evolved and adapted to address the most pressing public health challenges, from suicide and overdose to child abuse and community violence, with a focus on groups of people who are disproportionately affected. The Injury Center's focus is on prevention, stopping injuries and violence before they happen. Our work is growing and evolving, and our priorities reflect urgent public health issues: preventing adverse childhood experiences, or ACEs, preventing overdose and substance use-related harms, preventing suicide. We also address violence and leading causes of unintentional injuries, including drowning, motor vehicle crashes, older adult falls, and traumatic brain injury, TBI. In addition, we serve as the CDC coordination hub for mental health activities. This map shows the fiscal year FY23 funding for our 3 priority topics: ACEs, overdose, and suicide. As you can see, all states and Puerto Rico receive funding through the Injury Center. This map shows the fiscal year 23 funding for ACEs. 12 states or tribal nations are funded to build jurisdiction-wide ACEs monitoring and prevention. This map shows the FY23 funding for overdose. 66 states, counties, and territories are funded to collect timely data on non-fatal and fatal overdoses, which inform prevention and response efforts. And finally, this map shows the FY23 funding for suicide. 19 states, 3 universities, Puerto Rico, and Bexar County, Texas, are funded to implement and evaluate comprehensive suicide prevention. 4 tribes also receive funding through a separate mechanism. Injury prevention. Unintentional and self-directed injuries are a leading cause of death in the United States. The Injury Center's mission is to prevent injuries by connecting data, science, and action through our initiatives. Here are 2 examples. Studying the effective strategies to prevent injuries and violence with 9 Injury Control Research Centers, ICRCs, community partners to ensure their research findings translate into practical actions and interventions. And funding 26 states through the Core State Injury Prevention Program, or SIP, to prioritize the prevention of ACEs, traumatic brain injuries, transportation-related injuries, and other injury topics that are of local concern. Violence prevention. Violence is an urgent public health problem. Our goal is to stop violence before it begins. Prevention requires understanding the factors that influence violence. The Injury Center supports research, programs, and practices that reduce violence and its health and social consequences. Our violence prevention work includes collecting data from all 50 states, Washington, D.C., and Puerto Rico, the CDC's National Violent Death Reporting System, NVDRS, to help define public health priorities, develop and evaluate programs and policies, and research state-level violent deaths. Supporting communities and local health departments to prevent multiple forms of youth violence. Homicide is the 3rd leading cause of death for young people ages 10 to 24 in the United States. We collaborate with 5 academic youth violence prevention centers to advance youth violence research and 8 public health recipients to implement evidence-based prevention strategies through the Preventing Violence Affecting Young Lives PREVAIL initiative. The Rape Prevention and Education Program, RPE, works to prevent sexual violence by providing funding to state and territorial health departments in all 50 states, the District of Columbia, Puerto Rico, and the U.S. Virgin Islands, and state, territorial, and tribal sexual assault coalitions. The RPE program is authorized through the Violence Against Women Act, passed in Congress in 1994, and most recently reauthorized in 2022. In 2026, CDC received additional funding to support program evaluation research on programs implemented through RPE. Advancing public health practice by awarding continuing education credits to over 9,500 users in 2023 and receiving 2 million page views on our Veto Violence webpage. The Division of Injury Prevention and the CDC's Injury Center leads CDC's efforts to reduce unintentional and self-directed behavior and supports the center's vision of everyone, everywhere, every day, safe and free from injuries and violence. Our mission is to prevent injuries by connecting data, science, and action to ensure everyone has a fair and just opportunity to achieve their highest level of health. We prioritize our activities and resource allocation to create immediate impact through data, science, and action. Data. Improve the availability, timeliness, quality, and use of injury data to inform science and public health practice. Action. Grow data-driven evidence and strategies to advance injury prevention and catalyze action. And finally, action. Advance implementation of evidence-based programs, practices, and policies that prevent injuries. The Division of Injury Prevention works to prevent transplantation injuries, traumatic brain injury, TBI, older adult falls, suicide, and drowning. We prevent injury and death from motor vehicle crashes, a leading cause of death in the United States, through education and intervention, providing state-specific data, resources, and proven strategies to help state decision makers select effective prevention interventions to reduce motor vehicle crash deaths. We prevent TBI, a major cause of death and disability for people of all ages, and improving health outcomes for survivors of TBI by building education initiatives and trainings, conducting surveillance and research, and releasing guidelines on TBI identification and management. Older adult falls. We prevent older adult falls, the leading cause of unintentional injury and death for Americans aged 65 years and older, by raising awareness with education campaigns and providing tools and resources for healthcare professionals to make fall prevention a routine part of clinical care. CDC's Comprehensive Suicide Prevention Program funds 24 programs to implement and evaluate a comprehensive public health approach to suicide prevention, with attention to populations that have higher suicide rates compared to other populations in the jurisdiction. Funded recipients are using data-driven decision-making to implement and evaluate the best available evidence. And finally, we partner to implement strategies to prevent drowning, the #1 cause of death for children ages 1 through 4, and the second leading cause of unintentional injury death for children ages 5 to 14. By addressing system-level barriers to assessing basic swimming and water safety skills training and collecting data to understand drowning risk. Here are a few Division of Injury Prevention products that were released in 2024. We released the 2024 National Strategy for Suicide Prevention, along with the Federal Action Plan. Vital Signs, Suicide Rates, and Selected County Level Factors, the United States, 2022. And Vital Signs, Drowning Death Rates and Self-Reported Swimming Skill, Lesson Participation, and Recreational Water Exposure, United States, 2019 to 2023. Now that I've provided an overview of the unintentional and intentional injury work at CDC and the Injury Center, I will now focus on the social and structural determinants of health.
I wonder if we'll see me when we know the car. Hey, Dad, I wonder if we'll see me when we know at the carnival today. Daddy, that's my friend AJ and his dad. Hi, Samantha. Are you going to the carnival too? Yep, I can't wait. Me neither. Hey, AJ, look. That school is a lot bigger and nicer than ours. Yeah, they probably don't even have to share rulers and markers in class like we do. And their playground looks brand new. A lot of things in this neighborhood look different from our neighborhood.
That's true, AJ. Some neighborhoods look different than others and have different resources too.
What are resources?
Resources are things like hospitals, stores, parks, restaurants. There are different types of resources in every neighborhood. Some communities have less resources than others, or resources that aren't as nice. The types of resources in the places where we are born, live, learn, work, play, and worship affect both our quality of life and our health. We call these social determinants of health, and they can be grouped into 5 major categories. Economic stability means people are able to afford things like healthy food, healthcare, and safe housing. Employment or job programs, career counseling, and availability of childcare can help increase economic stability in communities. People with higher levels of education are more likely to be healthier and live longer. But some children live in places with poorly performing schools, and many families can't afford to send their children to college. Programs to help children and adolescents do well in school and help families pay for college also help people be healthier in the long term. All people should have access to quality healthcare. Increasing health insurance coverage helps make sure more people get the healthcare services they need, like preventive care, including screenings and ongoing treatment for illnesses. Everyone should be able to live in a safe neighborhood where it is easy for them to make healthy choices. Safe and healthy neighborhoods have access to parks and safe sidewalks for walking and recreation, access to stores where healthy food is always affordable and available, and safe and reliable transportation. People's relationships and connections with family, friends, coworkers, and community members can have a major impact on their health and well-being. Programs and policies that help people have the social and community support they need are important for supporting health and well-being.
Yay, we're here. I'm glad the carnival is a resource we can enjoy.
Social determinants of health are connected and related to each other. Together, all of these things will help improve the overall health of the people. By working together, we can help ensure everyone has access to the necessary resources and support they need to be as healthy as possible. Learn more, take action, make a difference. Visit cdc.gov/health equity to learn more.
So this video provided a great overview of the five major categories of social determinants of health: economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and social and community context. And we'll be able to explore these more later on in the presentation. In fall of 2021, CDC leadership started an agency-wide process to build and expand cross-cutting efforts to address the social determinants of health. This effort was led by the National Center for Chronic Disease Prevention and Promotion and resulted in a framework of 6 pillars: data and surveillance, embedded consistent social determinants of health approach to standardization, collection, analysis, and dissemination of data across the agency; evaluation and evidence building, advance evaluation and build evidence or strategies that address the social determinants of health to reduce disparities; partnerships and collaboration, establish criteria, actionable steps, and strategies for partnerships, collaborations, and relationships that result in improved health outcomes over the long term; community engagement, foster meaningful, sustained community engagement across all phases of CDC intervention planning and implementation; infrastructure and capacity, strengthen and sustain infrastructure such as workforce, training, and access to financial resources required to address the social determinants of health and reduce health disparities; and finally, policy and law, identify evidence, tools, and resources to enhance communication about policies that affect the social determinants of health with policymakers and other partners. The CDC ATSDR Social Vulnerability Index, SVI, is a place-based index, database, and mapping application designed to identify and quantify communities experiencing social vulnerability. SVI is calculated using U.S. Census Bureau variables to rank county-level social vulnerability and is currently updated every 2 years. Social vulnerability refers to the demographic and socioeconomic factors such as poverty, lack of access to transportation, and crowded housing that adversely affect communities that encountered hazards and other community-level stressors. These stressors can include natural or human-caused disasters, such as tornadoes or chemical spills, or disease outbreaks, such as COVID-19. In addition to calculating an overall vulnerability score, CDC ATSDR estimates 4 social vulnerability themes: socioeconomic status, which includes unemployment, housing cost burden, no health insurance; household characteristics, including age 65 and older, age 17 and younger, single-parent households; racial and ethnic minority status; and housing type and transportation; multi-unit structures, crowding, no vehicle. Whiskers is our web-based injury statistics query and reporting system. Community health factors, including the Social Vulnerability Index, SVI, and county health rankings and road maps, helps to describe the role of social determinants of health on fatal injuries. Research and data show that fatal injuries disproportionately affect many populations. Examining the social and environmental factors that surround communities helps describe a more comprehensive picture of the root causes of injuries. These can be used to better inform injury prevention efforts. This tool is based on an analytic paper that examined the Social Vulnerability Index and unintentional injury rates in the United States from 2015 to 2019. And colleagues in Division of Injury Prevention led this work. County level age-adjusted fatal injury rates are per 100,000 population and are ranked by quartile: low, mid-low, mid-high, and high. Higher SBI ranking values correspond to higher vulnerability. The County Health Rankings and Roadmaps is a program that provides data, evidence-based solutions, and guidance to improve community health across the United States. It's a collaboration between the Robert Wood Johnson Foundation and the University of Wisconsin Population Health Institute. It includes over 90 measures across various categories to assess and rank the health of U.S. counties. These measures are divided into two broad categories: health outcomes, length of life, quality of life, and health factors, health behaviors, clinical care, social and economic factors, and the physical environment. For Whiskers, we use county health ranking and roadmaps data for 18 measures that affect injury rates. These include health outcomes, frequent mental and physical distress and life expectancy, health behaviors, physical inactivity, excessive drinking, insufficient sleep, access to exercise opportunities. Clinical care, mental health providers and primary care physicians. Social and economic factors, disconnected youth, income inequality, juvenile arrests, school funding adequacy, school segregation, and some college. And finally, physical environment, home ownership, long commute, traffic volume. For all quartiles, the low represents counties whose data fall in the lowest 25%, representing counties with the lowest vulnerability risk, while the high represents counties whose data fall in the highest 25%, representing counties with the highest vulnerability risks. Population estimates are aggregated from multi-year reports to produce rates. Now let's put these two modules to use: the Social Vulnerability Index and the County Health Rankings and Roadmaps, using different counties in your state: Illinois, Indiana, Michigan, Minnesota, Ohio, and Wisconsin. And can everyone see this webpage? Okay, great. So this is our Whiskers webpage, and the first page, it shows fatal injury rates 2018 to 2022, looking at the Social Vulnerability Index. And you can see it has a map of the entire US, it includes the number of deaths and the total population. If you go to change filters, you can select the state, years, either 5 years or 10 years, the intent, the mechanism, and then here either Social Vulnerability Index or the County Health Rankings and Roadmaps. So let's first start with Illinois. And I'll keep everything else the same. Okay, so you can see there were 48,693 deaths with a population of 63 million. And if someone, I'm not sure if everybody can come off of mute, but if you live in Illinois and you know a specific county, we can take a look at some different counties. So if we just take a look at the CAB, you can look at the social determinants of health measure quartile is mid-high, and then the age-adjusted mortality quartile is low. You can look at Hancock, Illinois. The social determinants of health measure quartile is low, and then the age-adjusted mortality quartile is mid-high. Ford, Illinois, it had mid-high and mid-low. One more. And then Wayne, Illinois is mid-high for both the social determinants of health and then the age-adjusted mortality. Let's take a look at Indiana. You see the number of deaths, 31,564. Eckhart, it's high for social determinants of health measure quartile, and then low for the age-adjusted mortality. J, it's mid-high for the social determinants of health, and then high for age-adjusted mortality quartile. And then Hendricks, it's low for both the social determinants of health and then the age-adjusted mortality quartile. And let's take a look at Michigan. Okay, number of deaths, 43,000. Mackinac, I'm not sure if that's the correct pronunciation. Social determinants of health measure quartile is high, and then the age-adjusted mortality quartile is mid-low. Dickinson, low for social determinants of health, and then high for the age-adjusted mortality quartile. And then Ottawa, low for both the social determinants of health and then the age-adjusted mortality. We'll look at Minnesota, number of deaths, 21,000. Marshall, it's low for both social determinants of health and the age-adjusted. St. Louis, mid-high for the social determinants of health, and then high for the age-adjusted mortality. And then Meeker, low for the social determinants of health, and then also low for the age-adjusted mortality. Let's go to Ohio. Number of deaths, 59,000. Defiance, mid-low for the social determinants of health, and also mid-low for the age-adjusted mortality. Mercer, low for both. Delaware, also low for both. And then Wisconsin, 28,000 on number of deaths. Ashland, it's high for both social determinants of health and the age-adjusted mortality. Marionette, mid-low for social determinants of health, and then high for the age-adjusted. In Vernon, high for the social determinants of health, and then mid-low for the age-adjusted mortality. And then Sarah, I'm not able to see the chat. Are there any questions specifically about the whiskers and looking at the social vulnerability index?
So there's a whole bunch of people who are interested in looking at specific counties.
Okay.
So I would just, think we would direct folks to the website to take a look at that.
Yes, and since I'm on Wisconsin, does anyone have a specific county in Wisconsin?
Sure, we've got Ashland, which I think you just showed, and then Dane County, which is kind of south central Wisconsin. One more, down one, nope, down, there we go.
Dane, okay. Okay. So let me go now and take a look at the county health rankings and roadmaps. And then if you look at this drop down, the 18 measures that I have listed, they're all right here. Let's take a look at frequent mental distress, and let's start backwards. Let's start with Wisconsin. Okay, and then this is Dana again that I ended with. Columbia. Calumet. Okay. And let's go up to Ohio. And I can definitely share this link with you all so you all can take a look as well. Hancock, Champaign, Clinton. Go back up to Minnesota. St. Louis. And then this guy will show you the darker colors are higher, and then the lighter colors have low. Rice.
We did have one question in the chat. What are the population numbers at the top of the screen?
The entire population, are you referring to the entire population and then the number of deaths?
I think it was for the entire population was the question. Yeah.
Okay. And this is with the drop down. So this is all intention. So I didn't select unintentional, I didn't select homicide, but you can select, and then the mechanism. All injuries, you could look at drownings, falls, poisoning, so you can play around with it. And then once again, there are 18 measures that you can take a look at as well. Michigan. You can see the darker colors have higher, and then once again, the lower colors are low. Go back up to Indiana. Indiana, high. Du Bois, low. And then finally, Illinois. Yeah, so like I said, you can share the link and you can play around with it and take a look at all of the measures for counties in your state. Okay, so let's put what we discussed into practice. I have some few scenarios focused on injury prevention. And then after that, we can kind of talk through some of the social and structural determinants of health that are in play. So I'll leave this up here for a minute or so to let everyone have a chance to read through it. So what are some of the social and structural determinants of health that are contributing to James's increased risk of falling as an older adult? And see, I'm not sure if people.
Yep. I can see living alone as one.
Okay.
no assistive devices, limited access to transportation, built environment, yeah, inadequate transportation, lack of transportation, yep, chronic conditions.
Yeah, those are all great choices. Yes, limited transportation options impacting his accessibility to healthcare services, the underlying chronic conditions, inadequate infrastructure, lack of handrails, or proper lighting for him. Correct. Okay, this one focuses on drowning. What are the social and structural determinants of health that are contributing to Michael's increased risk of drowning?
So it looks like we've got lack of access or lack of safe recreational options, lack of supervision, lack of community infrastructure, lack of recreational facilities, parents, disinvestment in parks and staff, yeah, unsupervised.
Yep, all of those. You need increase with water safety education, creating safer swimming environments, all play a role. And then our last one focuses on transportation safety. What are the social and structural determinants of health that are contributing to Maria's increased risk of being in a car crash?
So it looks like we have insufficient and inadequate public transportation, lack of reliable transportation. One person said how long it will take for EMS to get to a socially vulnerable area. Economic instability, lack of living wage, financial distress, underemployment, lack of access to family sustaining wages.
Those are all great. And yeah. So now I would love to hear from you about how you or your organization potentially integrates the social and structural determinants of health in the work that you do every day. And Sarah, I'm not sure, are people able to unmute themselves or only write in the chat?
I believe folks are unable, or sorry, are able to unmute themselves. So, Heather, is that right?
No, actually just the
Oh,
chat,
okay.
please. I'm
Okay.
sorry.
Yep, no worries. So I'll keep an eye on the chat. Mhm. So Cynthia says we have integrated social determinants of health screenings and a common technology platform available all across Iowa for this work. She mentions that she'd also love to connect with folks from Iowa for this work. Felice from Wisconsin says our work focuses on the role of alcohol businesses and alcohol licensing as a social, commercial, and structural determinant of health.
And as you all are thinking about that, what factors have contributed to your success or potentially presented some challenges in the work that you do?
Erica mentions we are involved in Stop the Bleed, hands only and full CPR classes. We are also involved in the Safe Kids and teach the safety of bike helmets and head trauma prevention. Shalonda from Michigan says we recently worked with the state of Michigan to do interviews with community members across the state to talk about social determinants of health and excuse me, how they see it impacting their communities. And she would love to connect with more folks from Michigan as well. Olivia mentioned we focus programming in areas with the highest social vulnerability index scores.
It's great to see you using that.
Cynthia mentioned low or no cost. The technology platform is a great thing to reduce barriers for community-based orgs to engage. We have staff who are spread very thin, though in adding social determinants of health screenings and interventions can be very hard. Felice mentions one challenge for us is the number of people who cannot visualize change. They either think of alcohol as normal, as an economic driver, or they believe that the Tavern League has too much power to allow change. Lori mentioned partnering with social work at our hospital is very helpful as they are more in touch with and aware of family needs, social needs and status. Mira mentioned screening individuals for alcohol misuse and substance misuse and injury survivor screens for those at risk of PTSD or depression, and then connecting them into resources depending on the outcome of the screen. Mental health first aid training, Narcan training, and Stop the Bleed training. Let's see, others. Erica mentions we have taught every school in Cedar Rapids Stop the Bleed and are pleased to be able to say that every school in the Cedar Rapids School District has received tourniquets and education, which is great. Olivia mentions translation of educational materials into several languages, in addition to using images and less text, excuse me. Folks mentioned partnering with marketing departments as a success. So yeah, lots of great ideas.
Great, thank you all for that. So to wrap up my presentation, I would like to share some resources that might be helpful. These include all of our topic areas, some that I covered today and some that I didn't, but hopefully you'll find those helpful. And then as you continue this great work in unintentional and intentional injury prevention, I would like to leave you with this quote from Amanda Gorman. "There is always light, only if we are brave enough to see it. There is always light, only if we are brave enough to be it." With that, thank you all so much for your time. And I did leave some time for us for future other discussion and then to answer any questions that you may have. So thank you all so much.
Thank you so much, Dr. Marshall Mullins. We do have a couple of questions already in the chat. I'm kind of scrolling back to earlier in the presentation, and definitely encourage folks to put questions in the chat and I'll try to get to them. So the first one is back to the whiskers data that you were showing earlier. Felice asks, are there crosshatches in some counties due to insufficient data?
Yes, there is. And let's see. And I can send you the link with more information. I'll put that in the chat with the background on our data collection and everything. So I'll get that to you.
Great. Just a comment from Emily, back again to the Whiskers data. She says the data are not temporal since the county health rankings are based on prior census data. And she just, mentioned that they don't take into account kind of real-time intersectionality of social determinants of health, such as natural disasters, migrant crisis, and political actions.
Correct.
Yeah, okay. Crystal asked a question as it relates to falls. So she said, an ongoing request that I have asked in our state, excuse me, is why the falls category cannot be better represented. An example is we have the category of transportation accidents divided into trucks, cars, motorcycles, drivers, passengers, etc. And so wondering if there's a way to kind of disaggregate data on falls a little bit, aside from presenting it in one data point.
And if you email me, I will definitely follow up with our falls prevention team in the Division of Injury Prevention and get back to you.
Great. Shalonda did ask, we have access to these slides? We will make all of the slides and any resources from the session will be available after the conference is finished today. And I'm just scrolling through the chat. I think I hit all of the questions, but we do have a few more minutes. So if anybody else has additional questions, feel free to pop those in the chat. We do have somebody who raised her hand, Krista. Unfortunately, we can't have you unmute. So if you have a question, please write that in the chat. And I'll be happy to make sure that gets asked. Let's give folks maybe one more minute.
And I'm not sure, I think I put something in the chat, but I think it just went to the panelist. If you would like to email me, my email address is kmarshall@cdc.gov.
Just leaving space for any final questions before we wrap up the session. All right. I am not seeing anything additional come through, but again, Dr. Marshall Mullins put her email here in the chat at kmarshall@cdc.gov. We'll make sure that that gets out to all of you. And again, the slides will be available after the conference is finished today. So again, thank you so much, Dr. Marshall Mullins, for this wonderful presentation. Really, really appreciate it. And appreciate your time and being here today. Thank you so much.
Very welcome. Hope you all enjoy the rest of the conference. Thank you all.
Yeah. So next up is a break. We have a break that is scheduled until 10:30 this morning. So we invite you to take a break, stretch, connect with your colleagues, and meet us back at 10:30 for our panel discussion on exploring intersectionality, in injury prevention. I do also want to remind folks that in the lobby, you can check out our conference folder that has some of our materials available for you all. Again, there's the opportunity for networking in the lobby. Krista has a question, is each session in the same room? So if you go back to the lobby, there will be a Zoom link that will be available for each session right before the session starts. Our breakout sessions are in different rooms, so make sure when you go to the lobby that you take a look and see which breakout session you would like to attend, and make sure that you take a peek under the sessions tab as well in that lobby to see where each Zoom room is. The intersectionality panel is the only session we have at 10:30. So there's just one link for that session. Again, looking under the sessions tab, you can see that there. Otherwise, we invite folks to, again, take a break, get up and stretch, and we will see you back at 10:30. Thanks so much, everyone.